Hello, my name is George Minowata, and I am a volunteer pulmonologist for the MAVEN Project. Thank you all for attending and being part of the MAVEN Project. I especially want to thank our friends at Clinica Sierra Vista, who serve the communities of the Southern Joaquin Valley, also known as the Central Valley in California, one of the most productive agricultural areas in the world, for hosting today's session titled Resistant Hypertension, to screen for secondary causes or not, with Dr. Lucius Wright. Before I turn over the mic to Dr. Wright, let me tell you a little bit about him. After fellowship, Dr. Wright became medical director of the dialysis unit at Brooke Army Medical Center in San Antonio, Texas, and then director of the Nephrology Fellowship. After separating from the Army, he went into practice with the Jackson Clinic in Jackson, Tennessee, where he established the nephrology service and eventually grew it to 6 physicians. Dr. Wright retired after 35 years of practice. During those years, he served as the clinic's chairman and then medical director. At Jackson Madison County General Hospital, 659-bed tertiary care facility, he served as the chairman of medicine for 3 years, 8 years in the medical staff leadership, including chief of staff, and 15 years on the board-level medical staff quality committee. He also served as medical director for Dialysis Clinic, Inc., with facilities in West Tennessee for 33 years. Now on to his talk, again titled Resistant Hypertension to Screen for Secondary Causes or Not. Dr. Wright, the mic is yours.
Well, since we've announced the title 3 times, I'll move off the slide so y'all can see that we have no conflicts of interest. As he noted, we've been approved. I've got an old slide that talks about who approved it, but we've won a PRA. What I want to try to do today is to understand the definition of resistant hypertension, understand the other things that can cause resistance, sometimes called pseudo-resistance, understand the principles of drug management and non-drug issues that need to be addressed in your patient, and understand some new data on the prevalence of hyperaldosteronism and its implication for treatment plans. And as always, I like to start with a case. This is a real case from some years ago. 24-year-old fellow was in the hospital visiting his father, who'd had a stroke and had been admitted to the ICU. One of the nurses asked the young man if he'd ever had his blood pressure checked, and he said no. So she checked it, got 190 over 125 on several occasions, and advised him to see a doctor and get it further evaluated. He went to a primary care doctor in his town who checked his blood pressure and got similar values and started him on hydrochlorothiazide, 25 milligrams a day, and had him come back to see if things were better. Blood pressure remained elevated, so he ended up adding medications from the sample drawer, which included the HCTZ, a beta blocker, and a calcium channel blocker. But his blood pressure stayed around 170 over 90, so he was referred for further evaluation. He had a negative history, had never been sick, had no childhood illnesses out of the ordinary, did not smoke, did drink the occasional beer, denied illicit drugs, and did have, of course, the positive family history of hypertension. His physical examination showed a normal fundoscopic exam. He had no edema, no cardiomegaly. He was skinny at 134 pounds, and his blood pressure was 170 over 90. Lab had been done by the primary care doctor prior to starting any medication, which showed a normal CBC, urinalysis, and chemistry profile. So the question we want to start with is, does he have resistant hypertension, and should he be screened for secondary causes? Let's look at some definitions of resistant hypertension. It's usually defined as blood pressure that remains elevated despite the use of 3 drugs of different classes, one of which should be a diuretic. Uncontrolled hypertension is not the same as resistant, because the latter include those taking inadequate regimens or those who are not taking their medications in addition to those who are resistant. Prevalence is unknown, but it's estimated in some studies to be 25 to 50% of patients with hypertension. I think that's a little high. My clinical experience suggests that true resistant hypertension is more in the 10% category. So you'll see it, but the majority of folks do not have resistant hypertension. It matters because the mortality rate over time is much higher in people with true resistant hypertension. This looks at cardiovascular mortality. It never gets to 50% over the first 25 years or so, but you can see there's a substantial increase in mortality associated with resistant hypertension. So you want to try to avoid that, and you want to try to make sure you've got the patient on an adequate regimen. There are some patient characteristics that are associated with resistant hypertension. Older age, typically with systolic hypertension, high baseline blood pressures. Those who present at 140 over 100, 190 over 140 are more likely to have problems than those who present at 180 over 92. Obesity matters, excessive dietary sodium intake, chronic kidney disease, diabetes, left ventricular, excuse me, left ventricular hypertrophy, African ancestry, female, residents in the southeastern United States. There's some drug-related causes of resistance that are important to keep in mind. Non-steroidal anti-inflammatory drugs cause some sodium retention, which can override the blood pressure lowering effect of some pills. Sympathomimetic agents are commonly abused in the form of ephedrine, cocaine, and so forth. The stimulants are prescribed to large numbers of people: methylphenidate, dextromethorphan, and methamphetamines, alcohol, oral contraceptive, cyclosporin, which is one we use, but one you probably don't, erythropoietin, the same thing, and natural licorice, which acts as an aldosterone substitute. So secondary causes of resistant hypertension, I like to break them down into common and uncommon. The common ones are obstructive sleep apnea, renal parenchymal or arterial disease, and primary aldosteronism, not necessarily in that order. The uncommon ones are pheochromocytoma, Cushing's disease, hyperparathyroidism, aortic coarctation, and intracranial tumor. So the issues to consider is the most prevalent problems, as I've mentioned, are the obesity, renal disease, sleep apnea, sodium intake, and medication non-adherence, which needs to be in every list. And although the exact prevalence is unknown, everything else is a distant second. So initial efforts need to be directed toward treating, if possible, these contributory factors. A couple of general principles to keep in mind. One is pill burden. Anything that involves more than once daily dosing is not preferred because people will skip or miss the second dose. A third dose is almost guaranteed to be missed by the average patient. So you want to push the drug to the maximum effective dose before you add a new compound. And keep in mind that some side effects are more likely to produce non-adherence: xerostomia, erectile dysfunction, lethargy, malaise, things that make people feel bad when they weren't feeling bad are more likely to make them stop taking the medication. So does this patient have resistant hypertension? And the answer, in my view, is maybe, because it generally takes a month or two for drugs to have maximum effect, but he hasn't been on anything that long yet. He's not obese, denies using illegal drugs, has normal renal function and electrolytes, and eats the standard Southern American diet, which means it's fried, salted, and high calorie. Assuming he proves to be resistant, should he be screened, and if so, for what? I want to give you a few facts to know about screening. And this is the digression that always bogs people down, so bear with me, because we're going to talk about Bayes' theorem a little bit. In any test that you've got the tests that are true positive and true negative. You also have tests that are false positive and false negative, which are A, B, C, and D on this diagram. And it's in the slide deck, so you can study it in more detail. A more useful way to think about it is that the sensitivity of a test is the true positive divided by all the positive tests times 100. The specificity of the true negative divided by all the negative times 100. They both presuppose you know the actual incidence of disease in your population, which of course you almost never do. A better way to think about it is the positive predictive value, which is that patients who have the disease, or the true positive test, versus all the people who have the disease, and then the ones who don't is for the negative predictive value. But both are sensitive to the prevalence of disease in the population. So here's the slide I really want you to remember. All of these tests depend on what's going on in the population at risk. So if you order a test just because you can, and you get a result back that's positive, you have no way to know whether the test means anything or not if you don't have a reasonable pretest probability of disease. Let's assume we have a test that's 95% sensitive and 95% specific, which would be a real good lab test. As you can see from this slide, the positive test is truly associated with disease more than half the time, only if the prior prevalence of disease is at least 10%. And a negative test, once you get over 40%, becomes progressively less useful. So the sweet spot, so to speak, in these tests is somewhere between 20 and 40%. Now, estimating prior probability of disease is a bit of an art form, but it's one I encourage you to think about when you start ordering lab tests, because the ease of ordering lab tests overrides thought in way too many cases, and it leads to confusion. And I get a fair number of consults that are generated by lab tests that probably shouldn't have been ordered in the first place. And it's hard to know what to make of those. So let's do some prevalence estimates in the population. Roughly 5% of young adults with hypertension have secondary disease. It's usually white, often female, and frequently fibromuscular disease. 15 to 20% of older patients usually have atherosclerotic renovascular disease or associated intravascular disease in the kidneys. However, screening is not indicated unless the blood pressure is resistant to control, where there's excessive orthostasis with threats to perfusion of critical vascular beds like the heart, the brain, or the kidney. And in middle-aged adults, it may be on the order of 10%, with hyperaldosteronism being the most likely cause. These are some old slides, but they give you some idea why it would matter looking at primary aldosteronism, because I want to talk about some of the issues with that. Stroke, heart attack, sustained arrhythmia, and peripheral arterial disease are all more common in populations of patients with proven primary aldosteronism compared to those with essential hypertension. The new idea is it's more common than previously thought, but part of it depends on the difficulty in making a diagnosis, which I'm going to try to touch on. I don't expect you to remember the numbers, but the data are in the slide deck if you want to study it a little more closely. The aldosterone plasma renin activity ratio greater than 21 points to 20 to 1 points to aldosterone excess, but it's complicated because of the range of results. The aldo levels need to be high, but renin should be on the low side. And almost everybody you'd want to study is already taking medications that affect these levels as well. And I don't recommend stopping the pills to get a good test. I think that's a bad idea. Confirmatory testing is required to make the diagnosis, none of which is easy to do in an outpatient setting. So but all of them are designed to look for non-suppressibility of aldosterone in situations with oral or IV saline loading. Localization is best done with high-resolution CT scans, and serum potassium levels are commonly normal in patients with established disease. We used to say if they had normal potassium, you didn't have to worry about it so much, but that doesn't turn out to be true. So here's some aldosterone levels in patients with hypertension, and what you can see is probably best illustrated in the panel on the bottom left, which looks at urinary aldosterone excretion in various stages of hypertension, including treated resistant hypertension. And the most obvious thing is while there are some shifts in the middle, there's an awful lot of overlap. So any value that you get is going to be very difficult to interpret. The 24-hour urine aldosterone excretion is on the order of 15 micrograms per day if you have treated resistant hypertension, which is going to be pretty close to the diagnostic limit in a conservative management. Oops, wrong way. This slide is unreadable to you, I know, but it's important data. What you need to know is that the liberal definition of aldosterone excretion greater than 10 micrograms per day is a cutoff. The prevalence of overt primary aldosteronism is on the order of 14%. If you use a conventional definition where it's 12 micrograms per day, it's 9. And conservative definition is 4.8. So the prior probability of disease before you do a test is somewhere between 5 and call it 15% in round numbers. If you look at patients with suppressed renin on a screening test, the numbers change only slightly, not enough to matter in clinical practice. These data are from about 4 years ago in the Annals of Internal Medicine. So what are we supposed to do? What are you supposed to do when you see a patient who has a problem? So if there's a clinical concern for hyperaldosteronism, in my view, it's reasonable to do a therapeutic trial of spironolactone. If there's a good response, then formal evaluation to include localization is reasonable. If there's no response, I'd press on with efforts at blood pressure control. The rationale for this statement is that most of the patients I've evaluated did not have localizing tumors, so you ended up doing drug therapy anyway. And there's some evidence for an additive effect of aldosterone inhibition to renin-angiotensin inhibition in treating other forms of resistant hypertension, albeit at the risk of hyperkalemia. Renal artery stenosis in your older population is more common, and we've discussed that before. Typically an unenhanced MRA using balanced steady state precession sequences, which I can't really say, or inversion recovery pulses that have been published as showing good sensitivity and specificity. In my hospital, we did digital subtraction angiography because that's what everybody was more commonly familiar with. Contrast-enhanced MRA doesn't seem to work quite as well, but it's similar. All of them give you similar sensitivity and specificity. So your positive predictive value and negative predictive value are reasonably like the characteristics. The question becomes, what do you do with the data? Most current guidelines do not recommend screening for arteriosclerotic renovascular disease, as intervention does not result in cure. So when would I screen? I'd screen if the renal function deteriorated substantially in response to renin-angiotensin system inhibition, if the patient had major issues with orthostatic blood pressure changes, or perhaps if the renal function deteriorated markedly under observation with stable blood pressure control. Most chronic kidney diseases deteriorate over years. Ones that seem to be progressing over months are more alarming and would suggest the possibility of ischemia. Which leads me to the topic of ischemic nephropathy. This was a notion that got popularized some years ago because it was recognized that we were seeing lots of people in their 70s who were presenting with unexplained kidney failure needing dialysis. A lot of these patients also had arteriosclerotic disease. They had coronary artery disease and so forth. And so the thought came up that maybe these people had ischemic nephropathy and that they had renal artery stenosis, and if we revascularize their kidneys, they might have enough recovery of function to come off dialysis. And some early studies supported that idea. I got relatively enthusiastic about that and had a stable of people that had arteriograms that did not suggest lesions that could be intervened on surgically. And I had 12 patients that I studied over a couple of years. 4 had improvement with intervention, 4 experienced no improvement, and 4 got worse, 2 markedly so because of cholesterol emboli. Published experience replicated this anecdotal experience, and now with some additional criteria, which I won't get into, you can get, it's more like 50-50, so you're still tossing a coin when you do an intervention in these situations. So it's a rare indication for intervention, but criteria are idiosyncratic and vary from institution to institution. And the reason for that, of course, is because it's really equipoise. It's a toss-up no matter what you do. This is a slide that you can use to think about it a little bit more that summarizes some of the things that I've said. So non-invasive imaging suggests renal artery stenosis is present, and indications include circulatory congestion, deteriorating kidney function, and so forth, all of which lead to a repeat assessment. Let me go back to our patient before we get to the question, and the pun is intended because this is the patient of the patient's actual photograph of his back. And what you can see in this photograph is he's got several small spots of various sizes widely distributed all over his back, and they're kind of pink and red. And here are some up close that you can see much better. Now, I'll be honest, I didn't know what these were, but fortunately, when he was a kid, he had these too. And he'd been sent to see one of the surgeons in my multi-specialty clinic who had biopsied it, and it was a neurofibroma. So what we were able to establish on the basis of this is that this young man has neurofibromatosis, or von Recklinghausen's disease, or neurofibromatosis type 1, which is 90% of the cases. And pheochromocytomas occur in up to 6% of patients with neurofibromatosis. So that changed the prior probability of disease from vanishingly low to realistically in the differential. So I decided to go ahead and screen him for pheochromocytoma. His 24-hour urine was done that showed a creatinine clearance of 95 milliliters per minute. His urinary VMA excretion was 64, with no upper limit being 10. His metanephrines were 2.8, with the upper limit being 1, and his total free catechols were way off the charts. We did a CT scan that confirmed an extremely large mass arising in his left adrenal area. So we prepared him for, this is the CT scan, by the way, and it shows, if I can make this work right, shows the mass right here, almost looks like his kidney. This is what it looked like when we took it out after surgically preparing him with alpha blockade. And you can see that this thing is about 15 centimeters long. Following resection, his blood pressure improved, but 3 years later, he had recurrence of severe hypertension with elevated urinary catecholamines. Imaging studies confirmed metastatic disease, confirming that his original tumor was malignant. We'd considered that possibility given the size, but it turned out there's no histologic criteria. He died about 2 years later from his cancer. So the point I want to make from this patient was screening was not indicated until clinical findings increased the prior probability of disease enough to make it reasonable. The strongly positive results in the size of the tumor raised concerns about adrenal carcinoma, but histologically this was not confirmed. Only his clinical course demonstrated that it was indeed malignant. So screening for secondary hypertension is easy to order the lab tests. It's harder to know what they mean. And so the questions I would have you ask yourself when you're thinking about individual patients is, do they in fact have resistant hypertension, or are they just not taking the pills because they can't afford them, they cost too much, whatever. With that, I'll stop and move to questions. And George, I think, let me get out of the slide deck here so we can see a little bit better. There we go. So let's see. Let me see if I got questions in the chat box here. It looks like everybody's getting their CME credit. That's good.
Thanks, Dr. Wright. Let me ask a question. So when you're talking about a therapeutic trial of aldactone or spironolactone, you said a good response. What's a good response to spironolactone?
Yeah, it's basically the blood pressure moves back down toward therapeutic goals, which are to be the same in these patients as it would be in anybody else. Okay. So you'd be looking for blood pressures of 130, 120, that kind of thing, with systolics in the 80s.
Okay, all right. And then with the renal artery stenosis, you spoke about revascularization. What about, so that sounds like surgical. What about is angioplasty or some equivalent stent, something like that by IR? Is that an option, or is that not still feasible or safe in the
renal? Yeah, I didn't mean to imply most of these cases were done by interventional radiology, not by surgery. The problem is that a lot of our interventionalists suffer from the oculostenotic reflex. They see a stenosis and it needs to be fixed. Unfortunately, when it comes to blood pressure control and kidney function, it doesn't produce very dramatic results a lot of the time. So it's the kind of thing, we had a real serious disagreement with our local cardiologist for a while, because they were doing it sort of as a drive-by angioplasty on their way to the heart. They were going past the renal arteries and squirting dye in. And we tried to convince them that didn't make any sense because it wasn't helping. They thought it was because it looked prettier after they got through. But when we pointed out that their kidney function wasn't improving and their blood pressure wasn't any better, then we eventually convinced them not to do that without proper screening and thinking about it first.
So it sounds like, at least in the renal artery arena, there's still work to be done to better define what's a critical stenosis or the lesion, quote unquote.
Yes.
Coronary artery disease. That's
correct. The 95% stenosis thing they use in the heart doesn't seem to work as well in the kidneys. And partly, of course, you get collateral flow in some cases too. So that confuses the issue. Some people can have serious clinically important stenosis.
Okay, we've got a question in the chat. For newly diagnosed CKD, what are the baseline preliminary labs to order? We have an order set that includes BMP, CBC, phosphorus, a UA microscopy, protein creatinine, a random protein creatinine ratio, vitamin D, PTH, and renal ultrasound. The person asking the question prefers urine microalbumin to creatinine ratio, but what is preferred? What is the preferred urine study?
Most of those tests sound like you already know the patient has chronic kidney disease when you order them, as sort of establishing a baseline, because they don't really provide much diagnostic information. If you're trying to make a diagnosis of chronic kidney disease, then the urine, just plain old urinalysis is a good first step, and then the other one is the urine albumin creatinine ratio. Whether you do microalbuminuria or not, that's that's a lab test depending on what the local hospital, what your local lab can do. You can do either one, and you get the same information out of it. So what you're looking for is proteinuria, is a sensitive marker of advancing kidney disease. The creatinine is helpful, but it has to be indexed to the patient. And the point that I make in the other lectures that I give on chronic kidney disease is that the eGFR is a calculated number and is subject to considerable variation at the individual level. the presence of an abnormal eGFR with everything else being normal does not indicate the presence of kidney disease. I hope I answered the question.
Another question, should family members of those with fibromuscular dysplasia be screened or only closely monitor their BP?
I would monitor them. It's heritable in the sense that if one person's got it, other people may have it, but it's not like hair color and some other things that have a very high degree of genetic component to it. So if they're not hypertensive, for instance, I wouldn't particularly worry about it. So, you know, so you can make an argument for getting a blood pressure in just about everybody, but once you get past the blood pressure, I think you're probably getting into shaky territory where it's not useful. So if you see a young woman, for instance, with a vascular disease, you wouldn't necessarily want to screen all her brothers and sisters with anything other than a blood pressure.
What is there? I mean, you know, hopefully, you know, most patients are getting blood pressure checked intermittently throughout their life, but in terms of kind of screening or surveying family, is there, you know, an upper age where you would be less concerned, whether it's 40, 45 for fibromuscular dysplasia?
Typically it shows up before 40. So if you're going to have it, it's going to have it relatively early in life. But say it's heritable, but it's not how it's not a strong. It's one of those things that's probably a mixed effect. So it's not 50-50 or anything like that. So it's the kind of thing where I think about it, but I don't get carried away with it. And I would disagree a little bit with the idea that they're getting blood pressure. Women get their blood pressure checked because they have babies and that kind of stuff. Men don't have babies by and large, so they don't get their blood pressure checked unless they get insurance physicals or go into the service once they get out of high school. So, you know, a lot of people at 40 have never had their blood pressure taken by anybody. So at least around here, and I can't imagine it's that much different in California.
Other questions?
I saw one go by, but
yeah. So if there is a good response to spironolactone, if blood pressure improves, does that obviate the need for further evaluation, even though it raises the probability of an underlying cause of difficulty to control blood pressure? I think you're still looking for a tumor there, right? Whether it's adenoma.
Yeah, you can still look for a tumor. I think the question is asking if you have somebody who's resource constrained, or it would depend. If I had a healthy 40-year-old whose blood pressure required 4 drugs, including spironolactone to control, I'd probably be inclined to image them to see if there was something I could do that would cure them in quotation marks. On the other hand, if it's somebody who's got significant comorbidities, they've got a lot of other things wrong with them, and they're getting a good result. The end result is you want the blood pressure under control, whether you do it by operating on them or by giving them the appropriate medications.
Good. Other questions? Well, let me ask another follow-up question. So with fibromuscular dysplasia, is that assuming there's some genetic component, I mean, that may or may not be valid, but let's say there's a significant genetic component. Is the penetrance 100%? Is it, or I should say penetrance, but if someone has the right gene or genes, is it an all or nothing issue? Have, you know, mild fibromuscular dysplasia, moderate, and severe?
It doesn't seem to be predictable. In other words, the variable penetrance would be the way you'd probably put it in those terms. So you can have people who have no disease. You have people who have minor disease, and you can have disease in other beds. We talk about fibromuscular disease if it occurred primarily in the renal arteries, but it also occurs in other arteries as well. But we don't go looking at them because they don't seem to cause problems. So, you know, I think it's an understudied area is really probably the true answer.
Mm-hmm. Does treatment of sleep apnea help blood pressure control, or only if it is severe sleep apnea that is treated?
Sleep apnea seems to be associated with a lot of hormonal changes that are difficult to recognize, but certainly from a kidney doctor's point of view, fluid retention is common, and sort of Pickwick syndrome, if you will. And the reversal or treatment of the sleep apnea with positive airway pressure and the other things that are done seem to help improve the fluid retention and tend to improve the blood pressure, even if they're still having to use CPAP. So the answer is it appears that it's directly related to the fluid retention and presumably the other hormonal things that are going on. If you think about it, what the spouse always complains about is they wake up snorting and carrying on and flailing around and then go back to sleep again. Well, those are catecholamine bursts in the middle of the night, which probably aren't good for you, all things considered. Kind of like having nightmares all the time.
Hope that answered the question. Pickwickian syndrome also is, it's typically considered obesity hypoventilation. So those patients are going to have a low room air O2 sat even while awake. I have a patient with labile readings ranging from 180 to 190 over 80 to 90, sometimes within the same day on stable meds. I guess thoughts about that type of a patient with labile other than white coat syndrome?
Well, first off, you want to have the patient checking their blood pressure at home. The second thing to bear in mind is everybody's blood pressure changes from minute to minute and hour to hour. I'm sure mine is up higher now than it is when I'm half asleep watching something on television later tonight. I'll probably try to watch something on the Olympics and go to sleep like I have been. So, it's the kind of thing where there's normal variation in blood pressure, and what you're interested in is the average sort of blood pressure control. So I usually try to get patients who have difficulty to measure hypertension, is the way I'd put that. Try to get them to measure their blood pressure at home, but I usually try to encourage them to do it once a day, morning or afternoon, whichever is more convenient for their schedule, because there is this diurnal variation. Normal blood pressures are highest at 2 in the morning in healthy people, lowest about 4 o'clock in the afternoon. So you want to compare like to like, and what you're interested in is long-term trends, not absolute values. I've seen a fair number of patients over the years who've been turned into neurotic blood pressure checkers because they got a high value and they immediately recheck it and it's even higher than it was the last time. And the next thing you know, they're in the ER wanting sublingual clonidine or something like that to try to control their blood pressure. That's probably not helpful. So it's the kind of thing what misusing clonidine, yeah. Everybody's got that patient in their practice, the one who calls you up at 4 o'clock every afternoon and say, my blood pressure is 190 over 110. Am I going to have a stroke? And the answer is that treating high blood pressure reduces stroke risk over a long period of time. There's not a magic number of blood pressure that's going to cause you to blow your brain out right now. So in a patient like this, the first thing I do is de-escalate the number of measurements, but try to get them at the same time at home. And I usually try to encourage patients to weigh at the same time because fluid volume changes tend to be the most predictive of this kind of pattern. And if I found that the blood pressure was still running 190 over 85 or something like that, I'd say they have systolic hypertension. And I'd probably try to see what I could do to bring that down, typically with a diuretic or something like that. But so that's where I'd start first and go from there. But you have to be careful because treating systolic hypertension is difficult because if you get the diastolic too low, you interfere with diastolic flow in the heart and other places. So, if you get the mean arterial pressure too low, you can get into trouble. So you can't just treat to 130 and expect everything to work out okay. You may have to settle for 150.
Is hypertension associated with preeclampsia of a different etiology? Why do women with preeclampsia often go on to develop hypertension later?
Well, my response to that is going to be a little bit complicated. There are two separate issues. One is the diagnosis of preeclampsia. To the OBGYN, hypertension in a woman who's pregnant is preeclampsia until proven otherwise. but some percentage of those folks have essential hypertension or hypertension of other causes that it just happens to be made worse by being pregnant. And so, you know, you have to look at that. But let's take the classic preeclampsia, prima gravida, onset of hypertension somewhere around 32 weeks, leading to edema and eventually, if untreated, to seizures and requiring emergency delivery of the baby and so forth. If you look at those patients, they're not particularly associated with hypertension. There is some hormonal things that I can't remember the name of it right off the top of my head, but there's been a recent study in the last year or two that identified some hormonal factors that seem to be related to placental proteins that may seem to account for this. But what it boils down to is that in a normal, uncomplicated pregnancy, the mother vasodilates in an otherwise hypertensive situation because their volume expanded, they've got all the hormones floating around, and you would expect that they would be hypertensive, but they're not because they're vasodilated. And this particular molecule, let's call it, interferes with the vasodilatory response, so they become more like normal, which is bad because now they got all this extra fluid and all this extra hormonal stuff floating around, and it causes their blood pressure to go up to dangerous levels. So that's a little fuzzy, but since that's not a topic I reviewed recently, I can't remember the name of the substance, but I do remember reading the paper. So it is a different disease. It's not, but just to make it complicated, if you've got ordinary hypertension because everybody in the family's got hypertension, you can have it show up when you're pregnant because of all these stressors that you're bringing into the situation. I know that's not a satisfactory answer, but it's the best I can do for a complicated situation.
Can you comment on whether you should be more focused on, if it was an either or question, should you be more focused on the diastolic or the systolic blood pressure in terms of risk of cardiovascular outcomes, let's say?
Well, so cardiovascular and renal outcomes seem to depend more on diastolic blood pressure, but stroke risk seems to depend more on systolic. Some cardiologists think that the systolic matters more for old folks, but I worry that it's a marker of the degree of vascular stiffness as much as anything. So maybe an epiphenomenon as opposed to a causative phenomenon. So, you know, I think the official answer would be that you have to treat systolic as well. But as I say, with the caution that isolated systolic hypertension is much more difficult to treat. And if it doesn't respond to sodium restriction and volume removal with diuretics and maybe beta blockers, you're going to have real problems getting it down without causing problems with your systolic getting too low. If you get a systolic running around 50 or 60, your mean arterial pressure may be under 80 if you do the calculations. And so you're putting people who have known cardiovascular disease at risk for coronary ischemia and that kind of thing. So you're darned if you do it. Darned if you don't.
Sorry, just to clarify, if you focus too much on the systolic and your diastolic falls.
Yeah, if you're busy treating the systolic aggressively, the diastolic goes down lower than you want it to. So the issue basically is back when you and I had less gray hair, we used to say that systolic blood pressure of 160 was okay in old people, or the systolic was 100 plus the age was kind of the rule of thumb. So if you had an 80-year-old at 180, you didn't get too excited about it. That seemed to be associated with excessive coronary and cerebrovascular risk. So the notion became that we should try to treat for lower numbers, but now everybody's bought into the sprint targets of 120, and that's wrong too. So that's really the point I'm trying to make. You have to get an F on your scores in order to treat the patient right in some cases.
Treat the patient, not the test.
Well, I say it's tough because if you're getting paid on the basis of how many of your people are in range, the tendency is to want to try to get them in range and make them get you an A on the test. We're all A oriented. We all got into medical school on the curve and we all got out on the curve. So it's hard to get over that mentality.
Just to clarify, you did address the clonidine issue and a patient that in the chat that was described that was using or misusing clonidine.
Oh, yeah. So the issue is not that clonidine is bad, but the issue is that clonidine is easy for if you can give it to patients, say, well, take this if your blood pressure gets to pick some number. And what happens is they get to that number and they end up taking more and more clonidine. And once you get over about 0.6 milligrams a day, then stopping the clonidine is associated with rebound hypertension. So you can get yourself into a vicious cycle that goes worse and worse. The real problem, though, is you're making neurotic patients out of these folks because they're focused. Maybe they were neurotic to begin with, but you're not helping them to have them sitting there taking their blood pressure every 10 minutes and getting all worried because the number isn't 130/80.
I'm not sure if this is also related to that question or comment, but in the setting of clonidine is a part of I mean, it's generally in the hospital, but you know, treating withdrawal, whether it's alcohol or other
Oh,
substances.
yeah, it'll work. It works well in that situation. So, but there you got the patient under control. They're not self-medicating. You're ordering the medication.
Okay.
And if the patient was self-medicating to prevent his withdrawal symptoms, which I think is what I saw, or what it looked like it was to me, then that's actually appropriate, I suppose. But whether you want to continue to treat his withdrawal that way or not, that's up to you.
Yeah, probably better than taking whatever the substance he or she was addicted to.
Clonidine is probably safer than the other things that are out there.
Other questions from the audience around resistant hypertension? So it seems like the focus should really, if you're going to be thinking about it, should really be about primary hyperaldo, and then whether it's fibrodysplasia or renal artery stenosis. Those are
the two big ones.
Once in a blue moon, you might run into a FEO in
a referral practice where I saw lots of patients with difficult hypertension. The most common cause, of course, was chronic kidney disease, but that's because I'm a nephrologist. But I've seen 3 cases of FEO, and this is one of them. So, you know, it's not common.
Yeah. They're also associated with I forget, MEN1 or MEN2 or both. I can't remember.
I think it's in both.
Genetic syndrome.
Yes.
Multiple endocrine neoplasia, sorry. And they've identified, I forget what the genes are that are involved in those 2 syndromes. 8. Here are the diagnoses that can be entered to exclude the patients from HEDIS quality measures if isolated, systolic, and needs the BP to avoid stroke, for instance. Not sure.
I think I understand the question, but I don't know the answer. She's asking, is there some way you can get the patient kicked out of the count? And I don't know if that works or not. Most of the time, they just take whatever you got written down as the blood pressure. It's easier to count that than it is to look for excuses.
This would be to avoid the scenario of getting dinged for high blood pressure.
Yeah, I don't know that the system is flexible enough to account for clinical reality. The problem is the performance measure. So if you take the view that I've got to talk on this too, we can do some other time, but what it really boils down to is if you take the view that 90% of the time you should have the patient on the protocol, and the other 10% of the time you got individual variation that accounts for, and you got reasons for doing what you're doing that makes sense, you'd say, okay, we're going to do 90% of this measure, whatever it is. If you look at blood pressure, for instance, if you take the usual definitions of control and apply them to large populations of clinic patients. If you start out doing nothing except checking to see what the recorded blood pressure is, your adherence with the standard is about 50%. If you put a lot of effort into it and make it a priority, you can get that number up to 70%. What happens is people say, well, it's at 70%, but it ought to be 100%. It's never going to be 100%. And if you say, what's a reasonable variation, I would argue that 20 to 30% out of range is probably a reasonable number, not indicating bad care. But everybody wants to make something simple out of it. So we say if it's not in range, it's bad care. No, not necessarily. It may be a care that where you're ignoring the patient, but it may also be that the day you saw the patient, you knew they had 2+ lower extremity edema because of their ascites or whatever. Although that's a bad example, heart failure, let's say. And you didn't care about treating the blood pressure. You cared about treating the edema, which you gave diuretics for. So you did the right thing for the patient, but you didn't necessarily address the hypertension in a way that gets their number fixed before they go home. But it keeps them from getting into trouble, because if you lower the blood pressure and then try to get rid of the edema, you're going to have more edema and not get where you want to go. So if we could get a system that would allow for the idea that a lot of these performance measures, 20 to 30% variation is normal, and it doesn't indicate sloppy care or bad care, we'd be okay. Where we get into trouble is we make the elite from saying it ought to be X, and ideally it should be X, and everybody agrees that the data show it should be X. It's not X, therefore you're doing a bad job. That's the syllogism that gets us in trouble. And that's the one I'm objecting to, because that's not reasonable. Nothing's 100% in medicine.
I think for most HEDIS, at least outpatient quality measure, and even inpatient quality measure, I'm not an expert on this, but what I recall is that most of the numbers tend to be not 100%, depending on the issue. It could be 70, 80, 90%. I don't know the comment Gregory Vashon, if he could comment on that. I think most HEDIS quality measures have that kind of a target.
Well, a lot of them do
for a system,
yeah, a lot of them do, but at the individual level, it tends to become a blame game.
Yeah,
which is a misuse of the whole concept.
Yeah. Yes, BP control measures tend to be below 50% across the population.
Yes, that's been seen in several studies that have been published. If you just check the random blood pressures, but of course, part of the problem is that we're applying that 130/80 or 125/80. They had to go to the ER because they fell and broke their hip. I've seen that one before too.
Oh, and their BP's elevated, and you get dinged because their BP's elevated because they got acute pain, right?
Yeah.
That's the normal response. Yeah. But again, I think the HEDIS measures are right. Again, they're not 100%. I think there is wiggle room depending on the specific, topic, whether it's vaccinations or screening, cancer screenings, whatever it is.
Oh, I agree, but most of the counts are being applied by lay people, or the accountants are using this to decide what to do about it, deciding we got great care or we got sloppy care. Everybody's supposed to get 100.
Yeah.
It's the expectation.
Own scorecard and get.
Yeah.
Well, system's definitely not perfect. I think there's 100% agreement on that. Yeah.
I'm only arguing that people decide that they're going to not worry about being perfect. They're going to just struggle to do the best they can for the patient sitting in front of them.
I think that's what our remit is to do what's best for the patient in front of you. And often that's circumstances that you have very little control over. You try to figure it out, right?
Yeah.
The workaround that is going to help them may not be perfect for them, but it'll put them into a better place. Maybe not the best place, but better is better than where they are.
Well, a lot of MAVEN clinics are struggling with people who are resource limited, both in terms of insurance and in terms of just plain old cash in the pocket to buy a pill with. Yeah. So all the fancy lab tests, you'll notice I'm really not advocating for doing lots of fancy lab tests, because that runs the bill up, but it may not change the result. And maybe better off spending the money on blood pressure pills. cheap ones like ACE inhibitors.
Well, I think for things like high blood pressure, right? It's there's those are cholesterol, high blood pressure, diabetes, sugar control. I mean, those are population-based things that lend themselves to systematic approaches, and you try to take the individual, provider out of it in the sense of, let the system identify and support the provider to make it easier for them to do quote unquote the right thing, and so that the overall population benefits.
We had an interesting experience a number of years ago when folks from Procter and Gamble were trying to figure out what made for a primary care doc that was good for they were trying to manage their system. So they came to my clinic to explore the idea because we have a Procter and Gamble plant here in town. And what they did was they started off the presentation by talking about how they had invented the Swiffer mop based on market research that showed how this thing would solve problems that people didn't even know they had. And I told them after listening to the presentation, what we needed was somebody to convince the whole world how not to biggie size it. But we haven't, they need to put their skills to it because I'm not any good at that. I don't know how to do that.
Yeah. I think, yeah, I'm not sure all of this is going to get fixed, at least in our talks here.
Well, I call it swimming upstream. We're doing what we can to try to get the blood pressure in control, but the patient lives in an environment where they're surrounded by choices that may or may not be in their best interest, but we don't make it easy for them to do the right thing. Even if we know what the right thing is, we don't make it easy. And then we're surprised, we act surprised when it doesn't work.
I think we're all doing our best. BP control is environmental and marketing, yes. Yes. Well, it looks like we're out of questions. Again, Dr. Wright, thanks for a great talk, great discussion. And thanks everybody for attending. Again, if you want CME credit, please fill out the form that will be coming to you via email very shortly, or in the tab that should open up when you close out of this. Thanks again, Dr. Wright. Everyone have a good rest of your day. And thanks again for attending this MAVEN Project CME talk. Take care. Bye-bye. Let me end the recording.